Alright, so the first thing we're going to do, we're going to run through the functionality of the vent. Then we're going to talk about monitoring. And I'm going to teach Sean how to use the ventilator so I don't have to look at the eye. So the manufacturer makes it pretty easy for you to be able to figure out exactly what steps you need to go through to start the vent. So if you just follow the numbers 1, 2, 3, 4, 5 on the display, when you turn the machine on, the first thing you should do is calibrate it. So you're going to flip this knob all the way over to the calibration feature, and then on the screen it'll say mode cal, and then it'll say cal OK, so now you're good to go. So then you're going to figure out what mode of ventilation you're going to use. And we'll talk about modes of ventilation briefly, but this certainly is not a substitution for a true ventilator management course. So commonly, a patient that requires full support from the ventilator is best served in the AC mode. So this stands for assist control. So when we put a patient in assist control, that means that we're going to set a tidal volume and a respiratory rate, and the ventilator will deliver that rate and volume over the course of 1 minute. So right now the ventilator is set to give 12 breaths a minute with a tidal volume that we set at 500, and then it will deliver that volume and rate to the patient. If they're breathing spontaneously on their own, they can trigger a breath whenever they want. That's why it's called assist control. So it's not, there are mandatory breaths and non-mandatory breaths. The mandatory breath is one that the ventilator rate is set at. A non-mandatory breath is a breath that the patient will take on their own, and when they take a breath, because we've set a tidal volume of 500 and we're in the assist control mode, whenever the patient triggers their own breath, they're still going to get a 500 cc breath if that's what the tidal volume is set at. This is different than other modes of ventilation that we'll talk about in a minute. So in the AC mode, if we need to provide full support to the patient and the ventilator is doing all of the work and we don't really want the patient to breathe around that rate, then it's best that the patient be well sedated so that they're not fighting the ventilator rate. And we'll talk more about that in a little bit. So the next mode that we could go to is called SIMV. So this is called synchronous intermittent mechanical or mandatory ventilation. And so this is similar to AC in that it has a set rate, a set tidal volume, a set FiO2, so how much oxygen we're giving to the patient. The big difference between AC and SIMV is a non-mandatory breath. In the SIMV mode, if a patient wants to take 20 breaths instead of 12 breaths, the ventilator will deliver 12 breaths at a tidal volume of 500. On a non-mandatory breath that the patient triggers, if they only want to breathe 250 mils on a non-mandatory breath, then that's the tidal volume they're going to get delivered. So the machine will not mandate a volume in the SIMV mode on a non-mandatory breath. Does that make sense? Mm-hmm. Okay. So this is a more comfortable mode for a patient that is more awake and alert and allows them to regulate their carbon dioxide level on their own accord without us blowing off all their CO2. If we put the same patient in the AC mode and they were not well sedated and they triggered 20 breaths, then they're going to blow off all their carbon dioxide because they're going to get 500 cc tidal volumes every time they breathe. SIMV mode, they're going to get mandatory breaths and non-mandatory breaths, and the non-mandatory breath will be at their own leisure, their own volume. CPAP. So this is not a substitute for your CPAP machine that you may be thinking of where you put a patient on a mask. This is not non-invasive positive pressure ventilation. This is, the ventilator's alarming because you're not breathing. So I'm going to go back to the SIMV mode for a minute. So in CPAP, in order to use this mode of CPAP, the patient has to be intubated. They can't have a BiPAP mask on or something like that. They have to be intubated, and this allows the patient to breathe with some support from the ventilator. We can even set a rate if we so desire, but this is not a substitute for non-invasive positive pressure ventilation. So for the most part, in the transport setting, we're not going to have patients sitting in CPAP. We're usually going to have them in SIMV at a minimum, and we'll have them on a rate so that we can make sure they're ventilating adequately. So the next thing we're going to do is set a ventilation rate. So generally, most adults, we're going to ventilate between 12 and 20 breaths a minute. Children, we're going to ventilate a little faster very small children are going to go even faster than that. So the same ranges you would breathe for someone by the ACLS or PALS criteria, you're going to ventilate them the same with the machine here. What are we having alarms for? Let's see. Oh, some of this stuff is unhappy. Okay, so we'll say this is going to be a regular adult patient, and we're going to set a ventilation rate of 12 times a minute, which we've done here. So if you make adjustments with the knob, one of the downsides of this vent is that these knobs are extremely sensitive, and so it's very easy to over or undershoot the intended target. So I'm going to dial off our PEEP a little bit. All right. So we've set a rate of 12 a minute. The next thing we're going to do is we're going to look at the inspiration time. So most patients take a breath over about 3 seconds. So there's an inspiratory side of the respiratory cycle, and there's the expiratory side of the respiratory cycle. The inspiratory side is usually 1/3 of the expiratory time, right? So most of the time is spent on exhalation, not inhalation. So for the most part, most patients are going to be set on an IDE of 1 to 2, and the ventilator will make adjustments to the I time based on the rate that you select. So there's not usually a need for us to adjust their I time unless we need to extend the amount of time we're delivering a breath to them. So if they have a perfusion or an oxygenation issue, we may choose to extend their I time a little bit, but that comes with some risks. So we don't always necessarily like to do that. We're breath stacking on our test lung over here. Test lung was unhappy, sorry. Okay, so for IDE time, usually we're going to let the ventilator determine the I time, and we're only going to adjust the I time if we really need to increase the amount of time the patient receives the inspiratory side of the breath. But for the most part, I would recommend that you consult the respiratory therapist at the sending facility before you adjust their I time. There are some things that can occur with breath stacking if you have their I time too long. You can also increase the risk for barotrauma to their lungs by increasing their I time. So tidal volume. In general, you should set a tidal volume of about 6 cc's per kilogram of the patient's ideal body weight. So if you're transporting a patient that's a bariatric patient and they weigh 700 pounds, you should not take that kilograms of weight and multiply times 6. You should take what their ideal body weight should be and realize that a patient that's that obese, you may have to adjust a little bit more volume than what their ideal is to get their chest wall to really move. But the standard size adult, 6 cc's per kilogram of body weight of their ideal body weight is how we set their tidal volume. We do the same thing with kids. So there have been ranges that are as low as 6, as high as 15 cc's per kilogram for tidal volume adjustment. You should always start on the lower end of tidal volume, which gives you an opportunity to make sure you don't create trauma to the lung tissue. So we've set a tidal volume of almost 500 here. And on this machine, if you look, you'll see a tidal volume that's set, and then you'll see a tidal volume that's delivered. So if you want to know that the amount you set is actually what's being delivered to the patient, it allows you to see that measurement right here on the screen. The next we have the air oxygen mixer. Right now I have it set on 21% because we don't have a real good gas source at the moment. But if we had a patient that was on the ventilator, I would not anticipate seeing a patient on any less than 40% FiO2. And there's a lot of research out there to suggest that giving patients high tidal volumes, high FiO2 is not necessarily a great idea anymore. So we used to be really liberal about giving patients 100% FiO2, and now there's a lot of good information out there to suggest that we should give only enough oxygen required to maintain an O2 sat of about 98 or 99%. So that's, in the transport setting, that's a great way to make sure we're not giving them oxygen toxicity. So we can just watch their pulse oximetry as long as they have a good waveform and we feel comfortable with the setting that we have on there. An O2 sat of 99% is ideal. So that's 1, 2, 3, 4, 5. So if we needed to quickly get the ventilator ready to set up on a patient, we'll show you how quick it'll go. So we start over with the calibration mode. We put it on calibrate. Calibrate's okay. We select our mode. We'll say this is a very well sedated patient. We're going to go to the AC mode. We're going to set a ventilation rate. I'll say the rate's going to be 16. So now we have a rate of 16. We're going to set a standard I time. So the I to E ratio and a rate of 16 is 1.3 seconds is your I time. We're going to set a tidal volume of 6 cc's per kilogram. And so for the sake of discussion, we're just going to assume that works out to be about 500 cc's. And then we're going to select an FiO2. So we'll say this patient is on 85% FiO2. And you're going to see you're going to get an alarm if you don't have enough gas, which we do not. So if I set this thing for higher than it's prepared to deliver, it's going to let us know that there's an oxygen source failure. So it tells you exactly what's going on up here in the alarm, so it allows you to address what to do. So I'm going to bring this back down to 21%. Now you'll see the alarm message center light comes on, and everyone's happy. So there's some waveforms on the screen that are good to know about. There's you can see the Pleth waveform, so you can actually watch your breath go across, and you can see how the patient's airways respond to that breath. So this is giving you an idea of pressure in the chest. And then you can also see mean airway pressure and peak airway pressure right here on the sidebar diagram. And you can set high and low pressure alarms to allow you to regulate when you want the ventilator to let you know that the patient has reached a threshold of any of those pressures. So let's see. So we talked about AC mode, SIMV, CPAP. We talked about rate. We talked about I time, tidal volume, and FiO2 settings. So there's some other controls that we'll talk about with the ventilator. One is delivering a manual breath. You'll see down here there's a manual breath button. So I'm going to drop the respiratory rate here to about 9. So if I was listening to the patient's lung sounds and I didn't want to wait for the ventilator to cycle another breath, I could just hit this button and it's going to deliver another breath to the patient. Then the alarm button, this is one of the most important buttons on the entire ventilator. So if the thing starts to make noise, you can mute the alarm by pushing that button. It doesn't make your alarm go away on the message center, it just makes the sound go away. And if you don't address the problem, the alarm will come back in a pretty short interval of time. The sigh feature, you can program in a sigh if you want to give the patient a vital capacity breath. So if you're worried about them developing atelectasis in their lungs, you can program the sigh to be on, and it will deliver a sigh periodically to make sure you give the patient a full volume. We can also set PEEP. PEEP is really, really important for patients that are on mechanical ventilation. If you're not intubated, which we are not because we're all able to talk, we're standing in the room, we have a physiologic PEEP of 5. So our epiglottis is able to close when we get done with the breath, and because it can do that, we have our alveoli are intact. The minute we bypass the epiglottis and we put an endotracheal tube past the epiglottis, we drop the PEEP to 0. So the bad side about dropping a patient's PEEP to 0 is that now they're at risk for having oxygenation problems because they're not getting enough pressure to keep their alveoli open. So then their alveoli start to collapse, and it takes a lot of work on the ventilator's part to deliver back that PEEP. So you should never program PEEP with a patient attached to the circuit, because on this particular vent you can only go up on the PEEP. It doesn't allow you to come back down. So you run the risk of putting the patient at a PEEP of 20, which is a lot of PEEP. It increases their interthoracic pressure, and it can negatively impact their vital signs. So you want to make sure you give only the amount of PEEP required. So for a standard patient that you're just wanting to maintain normal physiologic parameters, a PEEP of 5 is adequate. If you have a patient that has congestive heart failure and they have a lot of pulmonary edema, and you're trying to control for their edema that they have, there's a delicate balance between regulating their blood pressure and regulating the amount of edema that you can clear out with a ventilator. So I would only set the PEEP high enough to be able to help clear out the alveoli without causing a drop in their blood pressure. So if you see their blood pressure drop in response to your PEEP, then you need to go down on your level of PEEP. And one common mistake that people make is they'll set PEEP on the ventilator and then they'll break the circuit several times over. So if I've had the patient attached, I'm going to move here to a real lungs, so let me have some alarms here for a minute. I move the patient over to here, and I decide that I want a bag, or I want a suction, or I want to do anything that's going to cause me to have to break the circuit. Every time I break the circuit, I lose all the PEEP we just worked to get. So sometimes it'll take 15 or 20 minutes to recover the amount of PEEP that you gained every time you break the circuit. That's why it's always valuable to have inline suction sets. That's why it's always really important to try to minimize the number of times you swap over from ventilator to ventilator or ventilator to BVM. So if I was going to do a transport where I knew I had a patient that was on a ventilator already, I would bring the ventilator to the bedside and not bag them out of the facility on a bag valve mask. That way you make sure you keep PEEP in the chest and you keep their alveoli open, which is what works best for the patient. So let's see. So we talked about high PEEP causing problems for the patient's hemodynamics. We can make sure that they'll crash their blood pressure if they have too much PEEP. We also set them up for lung injury if their PEEP is too high, and we also set them up for pneumothorax if they can't regulate that pressure in their chest on their own. Next thing, pressure alarms. So the ventilator has a high and a low pressure alarm. We would set a low pressure alarm threshold to let us know if we're not delivering enough pressure or if we've DC'd the circuit on accident and we didn't know it. So let's say the ventilator pops off and I've set my pressure alarm to, we'll say 5 or 10. When it doesn't receive that pressure coming back, it'll give it a couple of breaths and it's going to give me an alarm to check the circuit. It suspects there was a disconnect. So this acts as a safety feature to make sure the patient doesn't pop off the ventilator without you knowing about it. So high pressure alarm, if we're worried about having to be able to give the patient a lot of pressure without putting them at risk for pneumothorax, we can set a threshold for a pressure to go off, for an alarm to go off, so we can know if we might need to suction, or we can know if we're having to give the patient more and more pressure. If the pressure keeps building, chances are they're developing a pneumothorax. We need to monitor for that. So we want to give only enough volume to satisfy our oxygenation and ventilation requirement, and we assess that through monitoring. We'll talk about how we monitor that in a minute. Later. Some things about general safety. We want to make sure that we always have a bag valve mask and oxygen available. So it is not enough to bring a ventilator to the bedside. You also need to bring an oxygen source, and you need to also bring a bag valve mask. And you want to make sure you always have the BVM mask that goes with the BVM. So I've seen some pretty tragic scenarios of where a crew would have the ventilator, they would have a BVM, and then something would happen and the tube would get displaced. And if the tube gets displaced and I don't have basic airway adjuncts to put together, then I can't ventilate the patient. And if we paralyze them or deeply sedated them, then we've set them up for a big problem. So always make sure that you keep your BVM and your mask together. And I'll usually just run the tubing through the mask so that I always know exactly where my mask is, and it's just a second nature habit. So this should always be with you and readily available. You always want to make sure that the patient is fully monitored. So the gold standard for monitoring a patient on the ventilator is for them to have pulse oximetry in place and for them to have end-tidal CO2 monitoring. So a colorimetric device, although it's okay, they don't last very long, and if they get wet, they're pretty ineffective. So the nice thing about having a fully invasive monitor is that we have end-tidal CO2 available. So your end-tidal CO2 should be on the circuit so you can trend their CO2 and you can see how well they're oxygenating and ventilating. So remember, SpO2 is a measure of perfusion. End-tidal CO2 is a measure of ventilation and perfusion, really. So you can measure both parameters with end-tidal CO2 and pulse oximetry. You also want to have them on the EKG monitor so you can see their heart rate. You want to have the non-invasive blood pressure cuff on their arm so you can monitor their blood pressure, because you're going to make adjustments on the medications that they're on and ventilator adjustments based on what you see on the EKG. So all those things should be in place. So some people aren't very comfortable using a mechanical ventilator, and when they're new at it, they want to know who they can call. So if you're having a problem with a ventilater and you're in the sending hospital, the respiratory therapist is always a great person to talk to. They're usually really easy to communicate with, and they'll help make sure that the settings you have on the ventilator are adequate. And before you move the patient out of a safe environment, make sure that everything is working correctly. So an RT is a good resource to use. Also, the sending physician or the nursing staff that may be at the bedside are also a good resource to use if you want to make sure everything looks right before you walk out the door. And sometimes it's a good safety step before you leave to have the physician take a look at your monitor and see what the vital sign parameters are before you walk out. That way everyone feels good about what you're walking out of the ER with. Another resource that you have to use is to always call medical control. So Dr. Kiss, Tony, Brian Bahani, myself, we're always available if you need to make a phone call. Dr. Kiss and Tony are obviously the first step in the medical control chain, but Brian and I can be a resource for you as well if that's required. So some troubleshooting things. You never want to troubleshoot a ventilator problem with a patient attached to the ventilator. So if you start noticing that you have vital signs changes, you would want to take your bag valve mask, hook it back up to your oxygen source, take the patient off the vent, and bag them while you figure out what your problem with the ventilator is. It's always a really bad idea to try to troubleshoot the vent with a patient attached to it. And although it sounds kind of intuitive, you'd be surprised how many times patients will be on the ventilator and their vital signs are changing, and they know it's an equipment problem, and they don't know what to do, but they don't take the patient off the vent. Easy thing to do. Sedation and monitoring paralysis, analgesia. So if you have patients that are on mechanical ventilators and they have been awake for any reason, they're usually going to be sedated to some level with a medication that you're going to be transporting with you. That may be something that's a continuous IV infusion, or that may be something that you're going to have to control with syringe boluses. You want to make sure that the patient's hemodynamics are closely monitored before you pick what medications you're going to use to ventilate them with. So if a patient is hypotensive or they're really, really tachycardic, chances are you're going to make them worse by aggressively giving them high doses of narcotics or paralytics. If you have a patient that's chemically paralyzed, you definitely want to make sure that you are monitoring their end-tidal CO2 so that if they're not receiving a breath, you can catch that they're not ventilating well. If the tube gets pulled and gets placed in the esophagus, you'll never know until the patient's vital signs really crash if you're not watching their end-tidal CO2. So end-tidal CO2 is really, really important. So if you have any questions about the medications that you're giving or what the best clinical course of care for the patient would be, again, the nurse at the bedside, the sending physician, or medical control would be great resources to utilize to figure out exactly the best clinical course for the patient. I'm going to teach you guys an acronym called DOPE. And DOPE is a quick, down and dirty way to troubleshoot a ventilator problem. So the first thing that D stands for is dislodged. So if you have a ventilator alarm and you're worried that the tube might have gotten pulled, you might want to take your laryngoscope back out and take a look and make sure your tube's in the right spot. You want to always be aware of the depth of the ET tube at their teeth. So you want to make sure that if you started out with an ET tube at 21 centimeters at the teeth, that you arrive at the sending hospital, the receiving hospital, with the same depth measurement. Most adult patients are going to have an ET tube between 21 to 23 centimeters at the teeth is about an average. And if you have any doubt, you want to make sure that you have access to a chest x-ray before you walk out the door so you can see exactly where the position of the ET tube is. And the physician should feel good about showing you that. O stands for obstruction. So if the patient's tube is kinked, you're going to get a pressure alarm. If they have secretions in the tube, they need to be suctioned, you're going to get a high pressure alarm. So you can use a soft suction catheter and suction the tube. If the sending hospital has an inline suction system already attached to the circuit, I would bring that with me so you don't have to break the circuit, put on sterile gloves to do tracheal suctioning. Just a whole lot easier to use the inline circuit if that's available. The next thing is pneumothorax. If you have high pressure alarms on the ventilator and you don't have good lung sounds, then one of the things that you may have encountered is the patient's developing a pneumothorax. So if you see one side of the chest rising and not the other side, that's an indication that it's either a pneumo or the tube is pushed too far down one side. If their vital signs start to change, they start dropping their blood pressure, they have poor O2 sats, they have poor end-tidal CO2, and they have no lung sounds on one side, that's a pretty clear indicator they probably are developing a tension pneumothorax. So you may have to reduce the pressure in their chest with a needle thoracostomy. The last thing is E for equipment failure. So if you think there's a problem with the ventilator, take the patient off the vent and see if they'll tolerate ventilation with a bag valve mask. Some patients with really, really sick lungs don't like BVM ventilation, especially if we don't have a PEEP valve attached to the BVM. So if you have a sick patient that's required a lot of oxygenation, if they've required a lot of FiO2 or a lot of pressure, and they've required a lot of PEEP, you're not doing them any favors by removing all PEEP when you go to use a DVM. So a standard bag valve mask usually will have a cap that will pop off the top and allow us to put a PEEP valve on, and we can measure that amount of PEEP by the coil tension on the spring. So for physiologically stable patients, we're going to have a PEEP of 5. If they have sick lungs, we'll sometimes dial up to a PEEP of about 10. If you exceed a PEEP of 10, I would make sure you're really, really carefully watching their blood pressure. But always have a PEEP valve available. So this is some of the basics of mechanical ventilation with your EagleMed ventilator. If you have any questions, feel free to email the Clinical Services Department, and we'll be happy to offer you additional training.